Defining population health, especially today, is not an easy task. Let me give you an academic definition and then a more pragmatic one. We really trace the roots of this movement towards population health back to 2003 or 4, and the work of a colleague, Dr. David Kindick at the University of Wisconsin in Madison. And he first articulated the definition. It basically says, look, public health is pretty darn important. Clean water, clean air, vaccination, obesity reduction, no one could argue with that. But population health says, wait a second, there's also the cost of medical care, there's the environment, there's individual behavior, there's where you live and your zip code, because that turns out to be a key predictor. And then you put all that into a mixture, and population health punchline says, well, medical care is only 20% of the story, meaning 80% of what makes us healthy, ability to do our job, be happy, has nothing to do with medical care. So population health, in a nutshell, is all about what we now come to call the social determinants of health. Where you live, who your parents are, did you go to college, and all of those very important social issues. Population health today is not a medical specialty. It certainly is a special area of interest, inquiry, scholarship. We're very, very happy that we have the first College of Population Health in the country. There are 5 universities right behind us, but here at Jefferson we're very fortunate to have the very first college. So I wouldn't call it a medical specialty, but it certainly is a special area of interest and scholarship and, of course, study. I was very fortunate to give what's called the Simon Dack Lecture. So Dr. Dack was one of the founders of the American College of Cardiology and their journal, the Journal of the American College of Cardiology. So it's an honorary lecture, and I had the privilege of being selected to give this address. It's 25 minutes only, but it's the opening event of the annual ACC in Chicago. It was really a lot of fun. I'd never been in a room with almost 4,000 cardiologists, and my job, and the reason they selected me, was to discuss what's population health and why should cardiologists care. The connection between population health and cardiology is actually vital, and some of this goes back to a commitment that the American College of Cardiology has made this past summer 2015, by saying the following. Look, it's not about catheterizing everybody searching for coronary disease. It's to prevent coronary disease. It's not about doing bariatric surgery to reduce the risk of coronary disease. It's about appropriate exercise and diet. The leadership of the ACC calls it upstream medicine, which I think is a good phrase, and in their presentation in Chicago, the leaders called it shutting off the faucet rather than mopping up the floor. So at the national level, ACC has made this commitment that they're going to promote population health, primary and secondary prevention rather than intervention at the end, which I certainly applaud. I think another part of this is population health also means that we're going to be more careful about our resource use. So that means maybe putting in the 13th stent in a patient who can never really afford to take their medication in the first darn place is probably not a good idea, and certainly not good public policy. I applaud the ACC for tackling what for them must be a pretty tough issue, and that is moving away from all the procedures that they've trained for to thinking about, in their words, shutting off the faucet, upstream medicine. And I tried very hard in Chicago to elucidate these issues in the clearest way possible for an audience of 4,000 cardiologists from all over the country.